Good afternoon, everyone, and welcome to today's Lunch and Learn session, Part 2 of LPCA's Social Determinants webinar, Be Prepared, How to Stratify Social Determinant Risk and How to Manage High-Risk Patients Using Prepare. I am Shannon Robertson, Clinical Education Coordinator with the Louisiana Primary Care Association. Today we are pleased to have fourth-year Tulane University medical student Ben Jones. During this one-hour presentation, he will review the protocol for responding to and assessing patients' assets, risks, and experiences, the acronym for PRAPAREd, and how to implement the tool in a clinical setting. He will also review resources that providers may use to assist patients who are impacted by specific social determinants. Just a housekeeping item, during the webinar, all participants will be in listen-only mode. Please type in your question throughout the broadcast in the chat box or click the option to raise your hand located on the webinar screen and I will unmute your line. All lines will be unmuted after the presentation for questions. However, if we run out of time, you can email your question and we will follow up with you after the webinar. And our contact information will be displayed at the end. Thank you for participating in this webinar. Ben, you may begin.
Hello everyone, and welcome to this webinar. I'd like to make a special thank you to Shannon Robertson and Tanya Canal for setting up the webinar. I'm going to show my screen now. And let's see if I can get that out. Okay. And I'd also like to thank Irene Coco from the ExCeL Primary Care Center, she's the healthcare center manager there, for her insights on the resources that the ExCeL Center uses. As Shannon mentioned, the purpose of this webinar is a brief review of the Prepare tool, some examples of how to work Prepare into your workflow, some resources to address the social determinants that Prepare tracks, and about halfway through the webinar we'll try unmuting participants to talk about successful measures that certain healthcare centers have implemented. However, if there's too much background noise, we'll have participants type their questions and measures into the Q&A function, and I'll read them out. One final note, there are a number of hyperlinks in this presentation, and it'll be easiest to access those hyperlinks in the PDF file of the slides that will be distributed later. With that, we'll go ahead and get started. This webinar is a continuation of the LPCA series on the social determinants of health by David Schuster and Harrison Martin. A recording of that webinar can be found at the address below. So why do we measure and address social determinants of health? Well, a University of Wisconsin study in 2008 of their state's social determinants showed that healthcare access and quality represented only 10% of health determinants. 40% of the health determinants were determined by behavior, including tobacco use, diet, exercise, alcohol use, and high-risk sexual behavior and violence. 40% of the health outcomes were determined by socioeconomic factors, and 10% of the determinants were the outcomes were determined by the physical environment. And as a physician in training, these numbers were surprising because they suggest that up to 90% of the health of the patient is due to factors that are limits outside of the office setting. However, if the physician and healthcare centers can help measure these determinants and refer the patient to appropriate resources, then there's a much greater chance of improving the health of the patient. In today's day and age of value-based payment, providers are responsible for outcomes. If healthcare quality determines just about 10% of the health outcomes of the patient, then the healthcare providers and centers need to find a way in which their patients are the highest risk so that they can determine their resources and distribute them appropriately. The classic example of social determinants of health trumping healthcare quality is the patient who gets an appropriate prescription for medication, but the patient can't afford them due to a low socioeconomic status or unemployment. And there are innumerable other examples, but it's important to be aware that social determinants affect health. So what is PRAPAREd? As Shannon said, it's the protocol for responding to and assessing patients' assets, risks, and experiences. And it's important to note that this tool mentions assets. Too often when we're quantifying social determinants, we think of the negative aspects about a patient, the things that can hurt them. But every patient has assets and qualities that make them a healthier candidate and a healthier patient. So we need to be sure we keep that framework in mind. So many health centers already track information that's required by the Health Resources and Service Administration, or HRSA, but many healthcare centers don't have a single standardized method to collect and record that data. So PRAPARE was created out of necessity to help healthcare centers and other providers to collect and apply the data needed to better appreciate patients' social determinants. The National Association of Community Health Centers, the Association of Asian Pacific Community Health Organizations, the Oregon Primary Care Association, and the Institute for Alternative Futures organized the PRAPARE project in September of 2013 with funding from the Kresge Foundation, Kaiser Community Benefit, and Blue Shield of California. PRAPARE is both a standardized patient social risk assessment tool and can be used to address social determinants of health at levels of the patient and the population. In order to be most effective, healthcare providers and centers must partner with non-clinical care organizations. PRAPARE has been piloted by teams in Hawaii, Iowa, New York, and Oregon, and more states are on the way. This slide was taken from the National Association of Community Health Centers and one of their presentations about PRAPARE, and I really like it because it shows the various levels that PRAPARE can impact. You start at the individual patient level where you try to understand your patient and get some quantifiable data and understand the extent of your patient and their population once you put them in aggregate. That allows you to make more informed clinical decisions and which resources you need to focus on building. And that leads to improved outcomes and lower total cost of care. And if taking it even broader, it can go up to the state and national level and suggest new interventions there. But it all starts with the data. You'll notice at the bottom here, when we're looking at all of the things that are necessary, the most important aspect is that we have standardized data that we can put together from all of the healthcare centers in the state. So what does PRAPARE measure? Well, it measures 18 social determinants of health using 22 questions. 6 of those questions are optional, and the variables listed here are organized into 5 categories. But I think it's more useful to see which pieces of data already auto-populate the PRAPARE tool from the medical record. So Uniform Data Services, or UDS, requires the items in red, and that can already populate the forms without much trouble at all. The blue domains are all part of Meaningful Use Stage 3, so it will be more important to incorporate those data in the coming years. The black domains in the bottom right-hand corner are optional social determinants that can be assessed at the discretion of the tool administrator. These social determinants all come from the paper version of PRAPARE that can be downloaded at the link below. So you might be thinking, what if my healthcare center collects all of this data already? Is it meant to replace my current tool? And the answer is no. You're doing a great job. But you might benefit from participating in the national learning community that's evolving as a result of the PRAPARE project. And you can sign up at the PRAPARE Project Resources page of healthcarecommunities.org. And note that PRAPARE is rapidly becoming incorporated into healthcare centers, and it reflects the most up-to-date collection method to align with nationally accepted measures. The closer your questions are to these measures, the more likely you are to benefit from standardized risk adjustment tools and resources. So as I mentioned before, the healthcarecommunities.org site and their resource center has a slew of documents that are really helpful in getting PRAPARE into your clinic. For the 4 most popular EMR systems, Epic, eCentricity, NextGen, and eClinicalWorks, they already have templates designed for you, and at this website you can use these tools to incorporate the templates into your EMR. And that's a really quick way to just get PRAPARE on board in your system. However, The PRAPAREd tool is much more than just an EMR and paper resource. It requires a lot of coordination between all of your workforce and even people outside of your workforce. So I like to think of it as the four rights: the right person, who will administer the tool, and who's going to address the social determinants; the right intervention, how will resource information be organized so that it's readily available and standardized for all of the patients; the right channel, how is the appropriate care team going to be notified to address the social determinants, and how is the right non-care service team notified; and what's the right time in the workflow for the PRAPAREd tool to be administered? When in the patient's visit does it make sense to administer the tool? And when is the best time to address the identified social determinants? Other significant barriers exist as well, like funding and training for the personnel to administer the PRAPAREd tool, funding and training to address the social determinants themselves. But of all of these, I think the right intervention format is the most challenging. And I'll go through some examples now. I'd like to take a couple minutes to talk through 5 sample workflows to give you some examples that you may wish to use for your center. So the first workflow has the PRAPAREd tool administered by an enrollment assistant, so someone specifically staffed to administer this test. And this would happen in the exam room right before the provider comes in. And so the PRAPAREd would be administered with patients who would be waiting for more than 30 minutes for the provider. And it's a nice thing because it breaks up some of the time that the patient's waiting, and it also provides enough time to discuss the social determinants with patients. However, some disadvantages that I thought of is that it could miss some patients in the morning because the providers are usually not overcrowded at that time, and they'll be able to get through patients relatively quickly. And as we're going through these, think about advantages and disadvantages to each of them in your practice, and try to think about which one is best for you, or even an alternative one that's better for you. The next example is that the PRAPAREd tool would be administered by the nursing staff or medical associates. They would be in the exam room before the provider enters, and PRAPAREd would be administered after vital signs and reason for a visit that is taken by the nurse staff and the triage staff. The provider would be able to review the PRAPAREd data and then refer them to the appropriate case manager. The advantage of this is that the staff would be trained in collecting sensitive information, and it's very private. It's referred specifically to the physician, and the physician is able to address the problems. Some disadvantages is that the physician's entrance into the room may disrupt the question gathering and may lead to an incomplete assessment of the social determinants. So it's important to figure out how long your physician is in the room, and if it's possible to incorporate it during this time. The next workflow includes more non-clinical staff, but on a different side, like patient navigators, patient advocates, and community health workers. This would happen outside the office setting, usually in a patient advocate's office or office of another non-clinical staff. This would happen after the clinical visit when the patient provider refers them to the patient navigator, and the patient advocate would administer it over a much longer time period, so the patient advocate could really get into depth about some of the social determinants that are identified. What's nice is that the same person asks the questions and addresses the need. The disadvantages is that it takes more time. It requires a separate appointment, and some patients may be unwilling to compromise that amount of time. The next workflow shows medical assistants providing the PRAPAREd tool. This would happen in the exam room before the provider entered the room. And medical assistants would administer the PRAPAREd tool while the patient is in the room, but before the provider enters, similar to our second workflow. The advantages is that it gets the patient to the exam room quickly. But again, the provider can disrupt the assessment, and that can mean that the medical assistant cannot complete the PRAPAREd tool, leading to an incomplete assessment. And finally, we have one with care coordinators, and they use the no wrong door approach. And for those of you who are unfamiliar with the no wrong door approach, it enables patients to approach the agency with problems that they need to address without a preconceived idea of the problems or the services they think they should need. No Wrong Door provides workers with the capability to identify the client's needs upfront and identify the best way to proceed with the client, for example, to refer the client to an external agency or community service, to screen the client for eligibility, or to take an application for benefits. No Wrong Door also incorporates the concept of priority, complexity, and risk, or PCR, where the agency can provide a differential response based on the client's situation. For example, if a client is homeless and in urgent need of food and shelter, the agency may prioritize that client's application for benefits so it is processed quickly and assign a specialized caseworker to work with the client. So really, this is a flexible alternative, and really gives the patient kind of autonomy to figure out which needs are most important to them, and it requires the healthcare center to adapt. So patient advocates administer it and then can relay that information to the provider in the office. The advantages is that the staff may address similar issues in real time, but a disadvantage is that it's less standardized. It's hard to know exactly which resources are needed to be deployed for each patient. So it can be difficult if the healthcare center doesn't have all of their ducks in a row, so to speak, with all of their resources lined up. And so at this time, I'd like to check to see if there are any questions. And Shannon, have we had any questions yet?
Okay, Ben. At this time, Ben, I don't see where there are any questions in the queue.
Okay.
However, I can unmute the lines just to see. There weren't any that were typed in, but
okay.
Let's see. Okay, the lines have been unmuted. So if there's anyone at this point that's on the line that has a question for Ben related to what he's discussed so far, please feel free to go ahead and ask your question at this time.
Yeah, Ben, this is Tonya. Can you hear me okay? Shannon, Ben?
There we go. I think I can hear you, Tonya.
Okay, great. I just had a quick question regarding the research that you did on this. Are you suggesting that it will take up to 30 minutes to complete this particular tool?
No, actually. I think the 30 minutes was just to be sure that there was adequate time to address some of the social determinants simultaneously. What they found is that it actually took about 9 minutes to administer on average, which was anywhere from, I believe it was about 6 to 9 minutes was the range that they saw, or some of when they piloted this tool. So it doesn't take a significant amount of time, but it's just enough that it can disrupt the workflow a little bit if it's not strategically placed.
Thank you.
Thank you for your question. Are there any other questions?
Okay, no,
Okay,
at this time it doesn't seem that there are any more questions. You can continue.
Okay. Okay. So at this point, I'd like to talk about some of the social determinants and go into some measures about them and how the PRAPAREd tool assesses them, and some responses that may be helpful when thinking about these social determinants. So the ones we'll be focusing on are stress, education, with regard to both adults and children, employment, income, social integration, and housing. So the first one I want to focus on is stress, because it opens the door to a lot of other social determinants. And although it's number 17, question number 17 on the Prepare paper form, I think it's such an important question to ask. We all have some sense that stress impacts health, but healthcare providers don't always get at the core of the issue. Answering this question with even a little bit of stress leads to the further question, why are you stressed? Tell me more about that. And it's a great one to make sure that nothing is missed. And that might be why it's administered at the end, just because the patient has listed out a number of contexts and assets in their life, and something might be missed at the end if this question isn't asked. So how do we deal with stress? Well, Excelf has a really cool program where twice a month they meet as a group, and patients can come in and talk about anything that's stressing them out in their lives. They have a number of behavioral health experts who can provide coping skills, and it's really important to work with patients on this, because if you can prop a patient up and give them the skills to address the stress, it can go a long way in improving health and health outcomes. And another thing to think about is that you'll do a huge service to patients just by listening to them. Unloading the stress can help. And I can hear the providers saying, now I want to listen, but I just don't have time. Well, the best thing to do in that situation is really to refer them out to behavioral health specialists, counselors, psychiatrists, or others who can work with the patient to develop those coping skills. Excelf also offers a number of individual appointments for a variety of lifestyle concerns, including anger management, eating disorders, weight management, and others. And these tend to be a little bit more sensitive issues that are better addressed in a one-on-one setting. You can imagine that talking about anger management issues in a group could get out of hand pretty quickly. So it's important to consider one-on-one options as well. In order to broaden access to psychiatric services and counseling, Excelf also uses telepsych, which is a great way to provide flexibility to patients and providers. And at this time, I'd like to open it up again to the audience for just a couple minutes to see if one or two of the participants would be willing to share any initiatives that they have for managing stress of their patients. And please introduce yourself by name, organization, and role. And we'll give them about 30 seconds, and if no one wants to share, we can move on to the next social determinant.
Okay, all lines are have been unmuted. They are open for questions at this time. If you have a question or would like to share information, please do so at this time. Okay, and
All
I don't
right.
see any questions in our chat box either.
Well, if there are no further questions, we'll move on to the next social determinant. The next one I'd like to discuss is education. So it's really important to get a sense of how much our patients understand, but it's also important to be aware that even the most educated patients may not have good health literacy. There was a study back in 2008, the National Assessment of Adult Literacy, the National Assessment of Adult Literacy, which found that only 53% of people had an intermediate level of health literacy, which is defined as an ability to read instructions on a prescription label and determine what time to take the medicine, which is pretty striking because we think as providers, I think we often get the sense that, well, we've talked about it with our patients, they must understand what I'm talking about. And that's not always the case. It's really critical to use a number of different methods during the patient interview that take very little time to conduct, but they help make sure the patient understands. So as you can see here with the PRAPAREd tool, it's a three-step stratification. It's very simple, so it doesn't get bogged down in a whole lot of detail, just less than a high school degree, high school or GED equivalent, and then more than high school. So some of the resources that we can use to help educate our patients in their health are the teach back method, in which the patient summarizes your instructions back to you, and just the process of going through and saying what you've just heard activates, you're activating a number of senses multiple times. You're You have to comprehend it enough to repeat it back. You have to say it again in order to actually teach it back. And then you get to hear it for a second time, the first time being when the provider actually mentioned the methods to you. One-page handouts can be very helpful for patients to understand their diseases more, and they establish realistic expectations about medications. Now, I would caution that one-page handouts are great, except that they can often find their way into the trash can, and they are not a substitute for really going through a patient's disease and treatment plan with them in person. Referrals to educational services are other interventions that are extremely important. So these would be GED programs or professional skills training that can improve employment options, and it also relates to their children's educational attainment. So it really works on multiple social determinants, but we have to keep in mind that it may be unrealistic in the more elderly patients. And patients with lower educational achievement may require more targeted outreach. And examples of this would be like phone reminders about appointments and medications, letters, anything to kind of get that patient back in the door. But the key is always, as always, is to find out what works best for each patient. So again, we'll try open it up. I sense that people are a little hesitant to participate, and that's okay, but we'll just give people another chance to participate if they've had really good success in education resources.
Okay, our lines have been open for questions. If you have a question, you're free to ask at this time.
Okay. Hearing none, we'll move on to the next aspect of education. And we mentioned that educational resources kind of apply to both adults and children. And education of the parent really impacts the education of the child. And there are a number of ways that healthcare centers can help children overcome the obstacles of education as a social determinant. ExHealth and other centers run events where the health center gives away school supplies like backpacks, notebooks, pens, and other items that are really important for schooling and creating an appropriate learning environment. Child care or preschool programs like Head Start can provide child care resources as well. New books after pediatric checkups is a really great way to for providers and healthcare centers to show that they're invested in the growth of their children more than just the health setting, but also in their educational development. One aspect that I found was really interesting is encouraging parents to read to their children and offering parenting classes. A lot of times parents are just unfamiliar with what to do, and having that encouragement from a physician or a healthcare center can really help motivate people to provide resources for their kids and to know exactly what to do. Other things include health education workshops, so healthy cooking, nutrition, and asthma-friendly environment, ways that you can clean the house to reduce asthma as a problem in the household, and also healthy cooking. We've found that diets in the home are extremely important, especially with the obesity epidemic. So it's really important to help our patients realize the best ways to cook and to provide adequate nutrition for them. I'd like to move on now to the employment questions. So previous versions of the tool employed a more thorough breakdown of the unemployed options, but the otherwise unemployed helps to simplify it again. You can see there's one primary question here. What's your current situation? Unemployed, full-time work, part-time work, and otherwise unemployed with a specific qualifier that you can provide. Optional features that also help are work hours and number of jobs. And these questions work synergistically with the stress question because they can help identify work as a source of stress in the form of multiple jobs or heavy weekly hours. Additionally, asking questions about employment can reveal information about occupational exposures and can help inform referrals. Some resources about employment include assisting with job search and placement, training and hiring adults as workers in the health center, providing and referring to places that offer income-generating skills, training, and college-level courses for career achievement, offering micro-enterprise assistance and lessons in professional etiquette, financial literacy, and business development. I think that's a really important one because not everybody's held a professional job, and sometimes people are just unfamiliar with how to work in a professional setting, and providing workshops and resources for patients to learn those skills them maintaining a job and following through for their career. I'd also like to go back to training and hiring adults as workers in the healthcare center. This is can be both a really rewarding and taxing job. You have to have someone who's dedicated to performing that role, and Miss Irene Coco from Excel actually did this with a number of her previous employees at various jobs that she's had throughout her career, and it's a lot of work, but she found it to be extremely rewarding to put those people on their feet. Oh, I'm sorry. Before we move on, I'd like to, again, solicit any additional resources that other healthcare centers have provided to help out with the employment issue. So if Shannon, if we could open it up for participation from the audience, that would be great.
Okay, lines are open at this time for any questions or feedback.
And I have a question just in general. Why are some questions in Prepare optional? Like I saw that 2 of the questions for employment were optional and 1 was like required.
Okay. Hearing none, I'll move on.
Ben, we had a question.
To income. So this is a free risk response question and can help identify which benefits a patient is eligible for. And I'm not going to go into specifics about income stratification because I think it differs. Oh, we did have a question. Okay. I'll go back to employment resources. I couldn't hear it, no. I'm sorry, I understand that we have a question and I couldn't hear it. So we'll try to go back.
Okay, sorry. I was just asking whether, like, why some questions in Prepare are optional, because I know on the previous slide, like, some of the employment questions were optional and 1 was just, like, required.
Let's see. How about now?
Hello? Can you hear me?
Yes. Hi there.
Hi. Okay. So I have a question about why some of the questions in Prepare and the tool are optional and why some are required, because I felt like some of the employment questions were labeled as optional on the previous slide.
Sure. That's a great question. When they were trialing the Prepare tool, what they found is that the most important questions were the 22 that they identified, and they're listed on the online Prepare tool. And these optional questions can help focus if employment is identified as a key part of the patient picture. It's the primary problem with one of the primary social determinants for them. You can use the optional questions to kind of focus in, well, how much are you working? Are you working more than 60 hours a week? Are you working 3 or more jobs? Because then they can kind of find a way to work with that patient and try to either find different jobs, or if you're working less than 20 hours a week, finding a job at all. And it's really to further characterize the extent of the social determinant for the patient. Does that answer your question?
Yes, thank you.
Okay, great. Any other questions?
Jalen,
What's up?
do you set up the groups already?
Okay. I've muted all the lines, and there aren't any more questions, and there aren't any in the chat box. You can continue.
Okay. All right. And so we touched on income a little bit. We'll move on to the income resources. Enabling community members to start their own enterprises is extremely important because it's the more that you can prop up patients on their own without starting jobs for them is really helpful. Obviously, referring patients to individual jobs is important as a starting place. But if a patient's able to start their own business, they have they have a lot of buy-in. They can develop skills like financial literacy, business development, and it really gets the community involved. Another thing that's important is providing access to loans. You know, if you don't have a loan center within a couple miles of the healthcare center, it can be difficult for patients to acquire the money that they need on a short-term basis. And it's about, you know, advocating for community infrastructure and housing development projects. Those are infrastructure is an area that provides a number of jobs for patients and building new houses as well. So, you know, the more that you can advocate on a city council level as a healthcare center, showing politicians and community activists that these projects can really empower patients and improve health outcomes, it's really important. And it's really about empowering your patients. Does anyone have any questions or other resources about income resources?
Okay, again, all lines are unmuted for any questions or feedback.
Okay. Hearing none, and I believe I'm still hearing none, we'll move on to the next social determinant. The next one is social integration, and this is question 12 of the tool, and it relates to some ideas about how close people are with people that matter to them. So it's talking to friends on the phone, visiting friends and family, attending church or club meetings, and it's really to assess the degree of social isolation that a patient has. As we mentioned in our previous webinar, social integration can be really key to dealing with health problems. And it's a very simple stratification again by measures of how many times a week. And there are a number of different ways to address social integration. Patients with a high degree of social isolation, particularly with severe conditions, should receive greater health management, and that includes home visits and calls. Patients with low social integration might have difficulty performing activities of daily living, so more in the elderly or even in the disabled population. So these patients should get referrals to support groups, community activities, and volunteer services that work within the special populations for high risk of social isolation. The care team can work with socially isolated patients to develop a plan of action in case of an emergency when the patient needs help. For example, a hurricane, or if there's on an environmental level, or even just following a procedure at the hospital, or if they just get sick with the flu, any sort of thing that has a plan of action prepared. Other things that are important are promoting community safety and well-being. So this includes things like organizing opportunities for youth, adults, and seniors to volunteer, conducting youth-led community assessments and action plans, offering programs and activities to celebrate the cultural diversity and promote cultural enrichment, understanding sensitivity and inclusion, particularly among the adults and youth. Other things that are important are promoting family and social support with emotional well-being. There's a separate prepare question that's optional on domestic violence prevention, and the safety at home. But I almost think it should be mandatory just because domestic violence and safety at home are such important issues for health. If you can't go home to a safe environment, it's very unlikely that you'll feel healthy when you're there. Other things include coordination with existing community resources like churches and services provided by other outside agencies. And then really encouraging mentoring among children and seniors. So that includes things like peer mentoring with the children just a grade or two above, talking to the younger kids about healthy lifestyles and promoting just positive energy throughout the community. And at this time, I'd like to open it up again for healthcare centers to provide any resources that they've worked on the topic of social integration.
Okay, all lines are unmuted to provide feedback or any questions at this time. Okay, I don't see any questions in the chat box. Ben, you can continue.
Okay. So the last social determinant I'll be talking about today is housing, and it's a very simple two questions. What's your housing situation today? Do you have a house, or are you living elsewhere? So I do not have housing, staying with others, living in a hotel, in a shelter, on a park street, or a beach, or in a car, in a park. And then are you worried about losing housing? And this goes back to some points earlier about anxiety and stress, and can help the provider hone in on this area to provide guidance and resources. So some housing resources include advocating for the construction of low-income housing, and we talked about housing as a job source for patients, but it's also low-income housing can be important for the homeless population, and as a measure for them. Let's see. You can also refer to social workers and homeless shelters. For patients in low-income or subsidized housing, particularly with patients in areas with housing code violations, it's really important to make sure that patients aren't affected by things like mold, asthma, and rodents, or any other kind of triggers for disease. It can be really important to advocate for housing code remediation, of housing code violations to make sure that low-income houses are up to standards. There are a number of concrete house issues like repairs, cleanliness, toxicity. Making sure patients have electricity in their homes is also a huge measure to help. As we mentioned earlier, patients who are worried about losing their housing may find that it influences their mental and behavioral health. So those who are at high risk of becoming homeless may need to be connected with resources to help prevent eviction or foreclosure. And finally, working to centralize and integrate the strategic collection of health and housing data across the project partners is really important. So this is a part where engaging the outside community and other non-healthcare providers, but in the social context, providing resources and connecting with the healthcare center. So this time I'd like to, for the last time, ask for audience participation and any successful measures that healthcare centers have provided for their patients.
Okay, at this time, our lines are unmuted. Please feel free to ask any questions or provide feedback.
Hello?
Yes.
Yeah, hi. I'm Aurelia Celestine at Excel, and I sent in a comment. For some reason, I couldn't speak earlier, you couldn't hear me, but I wanted to just comment about something you said earlier about social integration, and just mention that one of the things we're doing at Excel in New Orleans is we are educating our patients about the New Orleans Recreation Department, which has a huge program right now where they are affording residents of this greater New Orleans area free fitness programs and free diet-related programs where they're teaching them healthy eating, and it's a great way for them to socially interact with others in their neighbors, and also learn a better way of living as far as healthy lifestyle goes. And so it's just a really good social integration piece that we've incorporated into our health care.
That's great. That's so important. And how did you develop that connection with those free fitness programs? How did you kind of learn about them?
Actually, someone from the New Orleans Recreation Department reached out to us, and as a result, we were able to get that person to come in and educate our staff about their programs, which are quite extensive. And from there, we started educating our patients about the programs. They've got several areas that they provide lots of activities for the whole family. And so we're educating our patients about that.
That's excellent. That seems very serendipitous and fortunate that an institution reached out to you. Do you know how they identified you as the primary provider for the area, or just to give the other healthcare centers kind of tips to get their name out?
Yeah, I think that because we provide health care to families who are low-income families, and that would be their primary target, then we were on their list of people to reach out to.
Great. Okay. And so I think that's another key aspect of all of this, is making sure that other institutions are aware of the healthcare centers. Advertising can be a little bit tricky, but just kind of word of mouth from our patients can be extremely helpful as well. Would you agree with that?
Absolutely.
Okay. Thank you very much for your comment. That was excellent. Does anyone else have any comments that they'd like to add, or any other resources that they've used and tried?
Pam, this is Tonya.
Hi, Tanya.
LPCA in the past has promoted the activities of the NEFUSA.org, which is the National Environmental Education Foundation. It's for children. It's a nature initiative where someone actually writes a prescription for the child to bring to one of the state parks, and we have state parks in Louisiana. We're blessed with that all over. So you can go to NEFUSA.org for any of the resources. I think I may have a few left in the office. Likewise, if you'd like to contact us. And I'd also like to know if anybody has any experience with the PRAPAREd tool being integrated into their electronic record yet. If there's anybody on the line that has the experience and can share that. Well, I do want to say that some of the electronic vendors, there are about 4 of them, are in the process of incorporating that and performing educational sessions for their clientele. So rather than starting with a paper tool, you may actually ask your vendor if they have an electronic tool, PRAPAREd tool yet.
Antonio, are those vendors the ones listed here, Epic, GE Centricity, NextGen, and eClinicalWorks, or are there other vendors as well?
That's correct.
Okay. Yeah, they started with the most popular vendors, and again, you can find templates for those resources at healthcarecommunities.org, and these hyperlinks will be included in the final slide deck that will be sent out shortly. Okay, are there any other resources that people didn't get a chance to talk about, or any other questions that we have at this time?
Hi. So do health plans, accountable care organizations, and Medicaid already collect a lot of this data?
Yes. One of the issues is that it's not a standardized collection method, and that's really what the PRAPAREd tool is attempting to fix. The social determinants I showed in red were already required by Medicaid, and the health resources, let's see, health resources, I'm forgetting the name. They're required by the Health Resources and Service Administration, excuse me, HRSA, and uniform data systems. But Meaningful Use Stage 3 is going to require those blue social determinants that I list here. And it's really important to have a standardized method for a lot of these because they can be a little bit tricky. Like stress, for example, is very difficult to quantify if it's not done in a standardized fashion. The same thing goes for social integration and support. Does that answer your question?
Yes, thank you.
Okay. All right. Moving back. There we go. So just to quickly summarize what we've discussed today, thank you everybody for your participation and talking about resources that you provide. Just to kind of wrap everything up, PRAPARE has a variety of uses and can really be helpful for guiding healthcare centers and how to treat patients who are affected by a number of social determinants. And when you're starting for a new resource, look for an example from somebody else. We've heard some great suggestions from other healthcare centers, and work with your primary care associations for help. That's more than likely that somebody's tried to do what you want to do, and they can help give you a starting point. And again, PRAPARE isn't the final answer, but it helps lead to questions that can bring context to the patient's health. So I'll have any final questions here?
It looks like we have one question in the chat box, Ben,
Okay.
that for those health centers that may be looking toward or have those EMR systems that may be looking to implement that PRAPAREd tool, do you have a cost on what that tool may be?
Yeah, so the tool itself is actually free. It's open source and can be, if you have someone in your office who's comfortable installing that template, it can be done free of charge. Now, a number of organizations have had representatives also come out to install that, and that's going to be based on, that charge will be based on the vendor who provides that technical assistance resource. But if you have someone, a technical assistant person in your healthcare center who's comfortable, it can be incorporated for free.
Okay. Okay, again, if you have a question, please feel free to ask at this time. And so far, there aren't any more questions coming in, but we will allow just a few more moments for questions.
And while we're waiting for questions, I can just, I'd like to thank the LPCA for putting this webinar on and provide my contact information, rjones25@tulane.edu. And then here's a list of some resources as well. But again, if you have questions, please feel free to ask.
Okay. And if there are no more questions at this time, I would like to take a moment to thank our Tulane University School of Medicine student, Ben Jones, for conducting this presentation today. LPCA will send out a copy of the slides to all attendees and post the recordings of the learning session to the LPCA website. And just a gentle reminder that part 1 of the social determinants webinar can also be found on the LPCA members only page. And this will conclude our social determinants webinar, and we just want to thank everyone again for your participation. Have a great day.
All right, thanks everyone.